Understanding myasthenia gravis, when communication fails. Myasthenia gravis, often shortened to MG, is a long-term condition. It primarily affects the voluntary muscles in your body. These are the muscles you consciously control. Think about blinking your eyes, smiling, or lifting an arm. MG causes these muscles to weaken significantly. They also tire out much faster than they should. The core problem in myasthenia gravis lies at a critical point. This point is called the neuromuscular junction. It is the special place where your nerve cells connect with your muscle cells. Nerves send signals to muscles, telling them when to contract or move. This communication is vital for every movement we make. In MG, this communication system breaks down. The messages from the nerves don't get through to the muscles properly. In the case of myasthenia gravis, the immune system targets specific proteins. These proteins are crucial for transmitting signals at that neuromuscular junction. When these proteins are damaged or blocked, the muscle doesn't receive the full message from the nerve. This leads directly to the muscle weakness and fatigue that define the condition. When breathing muscles are affected, it can lead to a life-threatening situation known as a myasthenic crisis.
In most cases of myasthenia gravis, the immune system produces specific harmful antibodies. These antibodies are the troublemakers. They mistakenly target and damage components of the neuromuscular junction. The most common type of antibody found in MG patients targets acetylcholine receptors. These are often called AChR antibodies. Acetylcholine is a key chemical messenger, a neurotransmitter. It carries the signal from the nerve to the muscle. A positive test for AChR antibodies confirms the diagnosis for a large majority of MG patients. Around 80 to 85% of people with generalized MG will test positive for these antibodies. This makes it the most well-understood form of the condition. Knowing about AChR antibodies has paved the way for many of the current treatments. These treatments often focus on reducing the immune system's attack or improving neuromuscular transmission. For those who test negative for AChR antibodies, doctors then look for another culprit. The second antibody is called MuSK antibody. MuSK stands for muscle-specific kinase. Understanding these common antibody types, AChR and MuSK, has greatly improved our ability to diagnose and manage myasthenia gravis.
Beyond AChR and MuSK antibodies, there's another less common player. This is the LRP4 antibody. LRP4 stands for low-density lipoprotein receptor-related protein 4. This protein is also found at the neuromuscular junction. It works closely with MuSK. In fact, LRP4 is essential for activating MuSK. Think of LRP4 as a partner that helps MuSK do its job of organizing the acetylcholine receptors. Current estimates suggest that LRP4 antibodies are found in only about 1 to 5% of patients who are double seronegative. This means they have tested negative for both the common AChR antibodies and the MuSK antibodies. Because it's so uncommon, many doctors may not immediately think of LRP4-MG. This rarity contributes to the challenges in diagnosing this specific subtype. This indirect impact on MuSK function explains why symptoms can be similar across different antibody types of MG. The end result is always the same: a compromised neuromuscular junction that cannot effectively transmit signals from nerve to muscle, leading to the debilitating weakness. The symptoms in LRP4-MG can vary. Some studies suggest that patients with LRP4 antibodies might experience milder symptoms compared to those with AChR or MuSK antibodies. However, this is not always the case, and severe symptoms can still occur. Understanding this distinct molecular target, LRP4, is crucial for identifying all patients suffering from myasthenia gravis. Recognizing the existence and specific challenges of LRP4-MG is the first step towards improving this situation for affected individuals.
Section 4, the challenge of diagnosis. Why LRP4-MG is often overlooked. One of the biggest hurdles with LRP4 myasthenia gravis is getting an accurate diagnosis.
Many patients with LRP4-MG initially receive a diagnosis of seronegative myasthenia gravis. This happens because standard antibody tests for AChR and MuSK come back negative.
When these common markers are absent, it can lead to a diagnostic dead end for some. Doctors might then question the MG diagnosis altogether. The lack of widespread awareness about LRP4 antibodies among healthcare professionals also contributes to misdiagnoses. Because LRP4-MG is relatively rare, it's not always on the radar during the diagnostic workup.
Many clinics and hospitals may not routinely offer testing for LRP4 antibodies. Even if a physician suspects a rarer form of MG, accessing specialized LRP4 testing can be difficult. Furthermore, the clinical presentation of LRP4-MG can sometimes be milder or have a slower onset. This might lead to symptoms being initially attributed to other conditions, such as stress, aging, or even psychological factors.
Patients might be told their symptoms are all in their head, when in reality, they have a treatable autoimmune disorder. The consequences of a missed or delayed diagnosis in LRP4-MG can be significant. Without a confirmed diagnosis, patients may not receive the most effective treatments.
They might undergo unnecessary tests for other conditions. They may also continue to suffer from worsening symptoms that impact their quality of life. Recognizing the existence and specific challenges of LRP4-MG is the first step towards improving this situation for affected individuals.
Section 5, Navigating LRP4 MG testing treatment and the path forward. Testing for LRP4 antibodies is a specialized blood test. It is not typically part of the initial screening for myasthenia gravis.
This test is usually considered for patients who exhibit clear symptoms of MG, but have tested negative for both AChR and MuSK antibodies. The test involves detecting the presence of these specific LRP4 antibodies in the patient's bloodstream. Currently, as of our understanding in 2025, the availability of LRP4 antibody testing is improving. However, it is still not as universally accessible as tests for AChR or MuSK antibodies. This limitation means that some patients who could benefit from this test might not have easy access to it. Regarding treatment for LRP4 antibody-positive myasthenia gravis, the approaches are generally similar to those used for other forms of MG. These treatments aim to manage symptoms and suppress the autoimmune response. The specific treatment plan will be tailored to the individual patient's symptoms and overall health. Looking forward, raising awareness about LRP4-MG is crucial. Both patients and healthcare providers need to know about this rarer form. Continued research is also vital. We need to better understand the exact mechanisms of LRP4-MG. This will help develop more targeted and effective therapies. Greater awareness and ongoing research will undoubtedly lead to earlier diagnosis and improved outcomes for individuals living with LRP4 myasthenia gravis, offering them a clearer path to managing their condition effectively.